Well, I've been studying hyponatremia for most of my academic career, and most of us who study hyponatremia have focused on more the effect on the brain, neurocognitive effects of hyponatremia. It can cause confusion, disorientation, delirium, and in severe cases, death because of brain edema. And our mechanisms that we've evolved in studies in animals have explained the basis for many of these symptoms. But it was individual patient experiences that convinced me that there were also more chronic, longer-term effects of hyponatremia. Then I decided to look at more chronic effects, and to do that, we simply took our short-term animal model of hyponatremia and extended it for longer periods of time, specifically 3 months. And because of an experience with hyponatremic patients who had premature osteoporosis and fractures, the first goal of that study was to look at the bones to see what happened. And we were both rewarded as well as to some degree surprised by the magnitude of the effect that we saw. The more typical case is the elderly patient with mild hyponatremia, which in most cases is never treated because it's felt to be asymptomatic. And in that patient who might have a serum sodium of 130 or 131 as opposed to over 135, we can only surmise what the additive risk is in lieu of actual evidence-based data from clinical trials. But we know that the incidence is substantial of the coexistence of hyponatremia and osteoporosis, as well as hyponatremia and fractures. So from studies that are presently ongoing in our database of 2.8 million patients in the greater Washington, Baltimore area in the United States, we know that the incidence of osteoporosis is increased 2.6-fold if that patient also has a history of hyponatremia and a low sodium. And by the same amount, almost the identical amount, there's a 2.6-fold increase incidence in fragility fractures in patients who have a history of hyponatremia. And so we're just beginning to probe the true clinical significance of this. And I would say its real importance is not so much the isolated production of bone disease, osteoporosis, fractures, but how it interacts with other risk factors, particularly in the elderly, because remember, the elderly are the group that have the highest incidence of hyponatremia, as many as 5 to 7% just in the general population, going up to 15 to 20% in patients who are over 65 in chronic care facilities such as nursing homes and ambulatory care centers. So this is the group that has multiple risk factors for osteoporosis, senile, postmenopausal, inactivity, sarcopenia, you name it, they've got them all. What we really don't know and need to understand is when you throw in hyponatremia on top of all those things, how much more does it make it worse? As I alluded to in my talk, it's not just that the hyponatremia worsens the bone mineral content and possibly the bone quality, it's also that hyponatremia independently causes some degree of gait stability and increased falls. So I think the true overall synergistic risk factor risk that's added by hyponatremia has to take into account not just effects on bone mineral content and quality, but also on the overall fracture risk, which also includes gait instability and falls. So when you put those all together, yes, I may be biased by virtue of studying this field, but I think it's a very significant risk factor for fractures, which has been not perceived over the years. And I hope that by presenting both at ASBMR and the European Calcified Tissue Society, I'll raise some consciousness about maybe we should start looking more carefully at hyponatremia as a risk factor for not just osteoporosis, but for fractures in general. I think the concept which is prevalent throughout medicine in the world, both the United States, the European Union, and elsewhere, is that levels above 130 are what are considered to be safe levels, meaning they don't cause symptoms and one doesn't need to correct them. Data from large databases show that there's an increased risk of mortality both as outpatients and inpatients, even within that so-called safe range between 130 and 134. Our data from our NHANES 3 analysis, as well as in our animals, is that we can already see turning on of osteoclastogenesis and increased bone resorption, even in that very mild range. So I definitely think that any patient under 130 needs to be looked at carefully with regard to their overall bone health, with certainly a bone mineral density measurement at a minimum. I think what remains the challenge for the next several years is to define the risk of even that mild hyponatremia group from 130 to 134, whatever the normal limit is. Usually at 135 is the lower limits of normal. Some labs are 137. Any sodium below the normal limit, I think, it confers some risk, and obviously the risk should be gradated to the degree of hyponatremia, we would think. I, at the present time, am unwilling to say that there is no risk at any level of low sodium. We will treat low potassium even when it's just mildly low. We'll treat low calcium. We'll treat low glucose. I mean, we know that there are metabolic consequences of every imbalance in terms of highly regulated mineral contents or hormone contents. And I think that the concept that there is some level of sodium where it really has no effect if it's low, I think that's a false concept, and I think we are just beginning to understand that and just beginning to define the ways in which it does or doesn't affect our patients' health. One of the reasons practitioners don't actively treat mild hyponatremia is it's not very easy to treat in many cases. Fluid restriction is difficult for patients. It's not adhered to very strongly. The class of vasopressin receptor antagonists are available, but they're very expensive and probably at this point in time not realistic for long-term use. But drug-induced hyponatremia is one of the most important causes of hyponatremia, particularly in the elderly who are on polypharmacy with many different medications. So there are three classes of drugs that in particular should be looked for in any hyponatremic patient. The first is antidepressants and the SSRI group, which have a particularly high incidence of hyponatremia. And in my opinion, because of the multiple risks of hyponatremia, a patient on an SSRI who's hyponatremic should be switched to a different antidepressant in order to avoid worsening or causing the hyponatremia. The second group is anti-seizure medications, and carbamazepine or Tegretol is the prime offender. Most neurologists don't like to switch a drug that works, so we're not always able to do it, but if it can be, I certainly recommend that. The big quandary is, as you mentioned, diuretics, because hydrochlorothiazide is a mainstay as first-line treatment for hypertension, regardless of age, but particularly in the elderly. And hydrochlorothiazide is actually shown to be protective against bone loss and fractures because it induces a positive calcium balance. So one might argue that, well, the diuretic, yes, it may cause hyponatremia, but in fact is beneficial rather than harmful for bone. Our studies in our patient database would question that, and the fact is that no one has ever looked at the particular subgroup on thiazides who are actually hyponatremic, by most studies around 8 to 10%, to see if they actually benefit or are at risk because of that. In our studies that we'll present in Chicago in next month at the International Congress of Endocrinology, the protective effect of thiazides on fractures and osteoporosis is lost if those patients are also hyponatremic. Certainly for a loop diuretic such as furosemide, where there is no bone protective effect, yes, hyponatremia, I think, is a bad prognostic factor for bone, and those patients should be carefully considered in terms of whether they really need the antidiuretic therapy or a particular antidiuretic therapy. For thiazides, I think we need more work to really understand this, but I would suggest that in patients on thiazides, if they can maintain a normal sodium, then that's fine, but the 8 to 10% who shunt, I think at this point in time should be switched to a different antihypertensive drug, of which we've got at least 30 or 40, if not more. So I think there are other treatment options available if they do become hyponatremic, 90% won't, and the thiazides would not be a problem.
Now, you spoke about bone-sparing glucocorticoids.
Absolutely.
Now, what does that actually mean?
So we know that glucocorticoids are really effective anti-inflammatory agents. They're used by about 1% of the population on a long-term basis, and they've been really revolutionised many aspects of the treatment of arthritis, asthma, etc. But unfortunately, they have really nasty effects on bones when they're used long-term, so they at least double the risk of fracture, and it's estimated that about 50% of people who take these drugs long-term will get a fracture as a result of using them. So the idea would be, could we develop medications which have all the good things about steroids, which tend to be the anti-inflammatory things, without any of the negatives, and therefore they'd be bone-sparing. It's clear that the real advances over the last 60 years with steroids have been in making them easier to use and more selective. So rather than chemists getting better at making them more powerful, they've got better at making them more localized, so they're absorbed better in certain tissues like the skin or the lung. But if they do get into the circulation, these steroids are now being designed such that they're broken down. So there's evolution all the time going on with inhaled steroids, that they're getting better and better with greater safety profiles. But there still remains a large number of people where they're not enough. They need broader spectrum treatment, and these tend to be with the oral glucocorticoids that we've used for over 60 years. So glucocorticoids work through multiple different pathways, and that gives an opportunity to try to dissect out individual pathways that might be more or less useful to target if you were trying to develop a useful anti-inflammatory drug versus one which is having effects on the important tissues like skin and bone. The classical teaching was that there are two pathways by which glucocorticoids work. One is where they bind as a dimer to the DNA in the nucleus, and these dimerized receptors then mediate all the positive, useful things that glucocorticoids do in terms of keeping your body healthy, whereas the anti-inflammatory effects are mediated via a single receptor, a monomeric form. And this is called transrepression, and that's meant to account for all of the dirty work that glucocorticoids need to do in switching off inflammation. And chemists have been very good at trying to separate out those two pathways. And the question is, in the body, will these actually turn out to be effective in general, in terms of things like obesity and skin, and more particularly, will they protect the bones? Compound A is an interesting substance. It was identified from a Namibian shrub, and the Namibian women had taken this shrub as a way of getting abortions, actually. So they clearly included very potent compounds, and one compound that they isolated and they worked on it a little bit, made little modifications, turned out to be an anti-inflammatory substance. Now, it's got a much longer name than compound A, but compound A really just identifies it was the main compound they found. And when they studied this in animals, then compound A appeared to be very effective in some situations where it prevented inflammation, but it didn't seem to have the same effects in terms of obesity and in terms of other adverse effects. And that made it a possible bone-sparing glucocorticoid. Now, some researchers, mostly in Germany, have taken this forward to really try and see whether this might be a useful compound to develop further in the context of a bone-sparing glucocorticoid. And in a couple of papers that they published, it actually appears to do very well. It is able to protect, or for the same anti-inflammatory effect, it doesn't have anything like the inhibition of the ability to form bone. Now, there are a few problems with it. It doesn't really play by the rules in the sense that it achieves its effect through a combination of transrepression and transactivation, rather than being black and white, as the textbooks would allow us to make us think. But it really proves the point that our classical understanding of how glucocorticoids work is a bit simplistic, and we may have to be a little bit more, again, dirty in the way we find these drugs. We might have to just search for lots of compounds that fit a certain profile, and then we test them again in hopefully in humans eventually. The problem with compound A is that when it's used in higher doses, the safety of it isn't guaranteed, and it may start to have toxic effects. So it's unlikely to see the light of day as a medication for human use, but things that are based on the structures and the properties that it has may well get there one day. So I think they remain a necessary evil. I think we're getting better at using them more selectively, and for lesser durations of time as other drugs become available that can so-called steroid spare. It spares the exposure to the steroid. But I think for many years to come, they'll need to be used. They'll need to be used when people don't really know what's going on, large dose of anti-inflammatory effect. But in the future, it's been 60 years since we've really had any new oral glucocorticoids, and I'd be surprised if we go for another 60 years. But if we do, I think that tells us that there's something really special about the type of steroids that we're using now that the chemists have not been able to mimic or to capture. And maybe we need to get a bit smarter about the steroids that we use now and really recognise that they are very special, and try and work on that basis.
I'm Richard Eastle from the University of Sheffield, and I was previously a president of the European Calcified Tissue Society.
And I'm Bente Langdal. I'm a professor at the Department of Endocrinology in Aarhus, Denmark, and I'm the past president of ECTS.
Yeah, so I had the honour of being the chairman of this session,
Yeah.
and after the meeting, lots of people came up and said how interesting the session had been. And the first topic was the one where people would say, well, we just didn't know about that. And that was the topic of the hyponatremia and increased fracture risk. So I was just going to reflect a bit on how I thought about that, and I'll be very interested to hear what you thought too. And so his presentation. And of course, he's not from a bone community. He's actually he's an expert on salt and water homeostasis, and so he came at the whole project with a different perspective, which was very interesting. But he was telling us how people who have hyponatremia are more likely to have an unsteady gait and therefore more likely to fall, and that would put them at fracture risk. And then the evidence that people with low sodium are more likely to fracture. And when he looked at the Endocrine study, he found the low bone density. So the clinical side, fairly good evidence that the treatment, that the low sodium does relate to osteoporosis. And very interestingly, he had that study where he'd given the antagonist of vasopressin, where the sodium came up, and when the sodium came up, the net bone resorption came down. So quite a good story clinically, but what made it particularly interesting and convincing was having the data from the animals, where the low sodium was associated with low bone density and alterations in bone structure, and the in vitro studies where it seemed as though it really was the low sodium itself that was the trigger for increased osteoclast activity. And so that raises all sorts of questions as to how would the osteoclast sense the low sodium. So it's like all things, you hear an interesting story, but you're left with lots of questions at the end.
Yeah, and I thought it was fascinating lecture as well, and I to me it was actually, probably I should have known that, but it was quite new just to hear it like spoken out that bone is also the biggest source of sodium in the body. So of course if you're in need of sodium, you probably just as when you have low calcium start getting it out of your resource organ, which is the bone, and the cost for that is losing bone and low bone mass and perhaps fractures. So that's it kind of makes you think a bit more about these patients. As patients, you should probably be more aware of and try to do the best you can for their bones as well. So
the whole presentation, it encouraged lots of discussion, and one of the discussion points was what were the clinical implications. And one of them was that if you have a patient with osteoporosis, you should definitely measure the sodium. And vice versa, that if you have a patient with a low sodium, you should definitely measure the bone mineral density. So that was a nice clinical lesson, I thought, that came out of his presentation.
And also the little twist about the thiothyroids, which we normally think are good drugs for the bone because they spare the calcium in the kidneys. But if you, as a complication to that treatment, actually get low sodium levels, then you're not treating the bones as well as you thought you would be. So that's another thing to look out for when you use diuretics in the patients, maybe. So
And the other kind of the thing that's also I think relevant clinically is that there is we are able to treat low sodium. So it's not as though it's some phenomenon that we can do nothing about. We actually can treat it.
Yeah.
We can treat it with being careful about, let's say, water restriction, and even by using active drugs as well.
Yeah.
So it's got a real point to it as the whole area.
Yeah, no, I think that's it kind of highlight, because sometimes you just, maybe these patients are a bit old, so it's okay for them to have a bit of a low sodium, but it's absolutely not okay. They fall more, and the bones are not good. So so we should take care and try to correct with whatever means we have the low sodium. So totally agree. Yeah, that was really I learned a lot as well. So
great.
Yeah.
Well, the second presentation, the one about bone-sparing steroids, then we've had hopes for so many years, haven't we, that we've finally found a steroid that might be less harmful on bone. And so Mark Cooper, who gave the presentation, it was a masterly presentation in terms of clarity, wasn't it? And
Totally.
and the way he explained the way in which we have glucocorticoid signaling. I really enjoyed that. And then he told this story about this plant that grows in Namibia, from which they've isolated compound A, as it's called.
Yeah.
And compound A ended up breaking all the rules.
Yeah.
So once he'd explained very carefully how the glucocorticoids signal through two different pathways, it turned out that the rules were broken by this particular herb. And it looked as though we're able to dissociate the anti-inflammatory properties of steroids from the bone harm, and that in, at least in experimental animals, you weren't getting the bone harm from this compound A. Unfortunately, it was didn't have the right therapeutic index, so it's not going to be developed for humans. But it does raise the possibility that in the future we might see bone-sparing steroids.
Yeah. No, and I think it's still important. Many people say, okay, we don't use steroids as much as we used before because we have all the biologics to use in diseases where we used to use a lot of steroid. But there's still quite a lot of patients out there being treated with steroids. So I still think it would be absolutely fascinating if people could kind of pursue that idea of separating these two. The good and the bad part of glucocorticoids. So that was really,
And then he had the sobering thought at the end that even if you were able to develop the super compound A, he did have the thought that it still could be harmful because the patients might be relatively glucocorticoid insufficiency and couldn't mount a good response to an infection. So an area which shows promise, but it's going to be a bit of a challenge, I think.
But it's fascinating. It has been going on for years and years and years, and there's still so many things we need to learn about how a simple thing like glucocorticoids actually work and how we can manage that. That was really good.
So that's very interesting. And
very,
so the final presentation was the one about thyroid hormones.
Yeah.
And so the story about thyroid hormones and bone has gone back many years, hasn't it?
Many years.
So we've long known that overactive thyroid is a major risk factor for osteoporosis, and we know all about the high turnover that you get with high thyroid hormones. And we've also come to appreciate that if we over-replace with thyroxine, that's a very common cause of osteoporosis. So we knew that already, and we also knew that if children have underactive thyroids, that really has a big effect on their growth and that they're very retarded. And so Graham Williams began his lecture by explaining all that to us and giving us the mechanism by which that happened. But then he went on to tell us some quite interesting things. One of them was that even thyroid hormone levels within the normal range do impact on a person's risk of osteoporosis. Yeah. So that was kind of an interesting observation that he'd made. And then he talked about something which I hadn't heard before, which was this story that of the signaling for thyroid hormones. There are two major thyroid hormone receptors, the alpha and the beta. And it seems that for the pituitary, it's the beta that's important, but for the bone, it's the alpha. And so he'd made this observation in his experimental animals, in his mice, but we didn't really know whether this was still true for humans. And so what was new was that just recently there have been 2 or 3 case reports where there's been a growth retardation as a consequence of the mutation to the thyroid hormone receptor alpha.
Exactly.
And so that proves that the experiments and the observations found in the animals is true for man as well. So that was very interesting. So our knowledge of thyroid hormone metabolism is definitely going forward in relation to bone.
Yeah, and I also think that we try to take that into the clinic and actually remember that these patients with thyroid diseases are patients that we should also keep an eye. We should also keep an eye on their bones and remember to do DEXA and follow up on them to see if their bones recover when they recover from their thyroid disease. So definitely.
So I think, having sat through those 3 presentations, we feel as though we have some new things to learn about hormones and bone. And I think at future meetings we can probably find a few more hormones to look at,
Definitely.
can't we?
There are many out there we can have a look at. Yeah, no, I agree. Yeah.
Great.
Great.